brings us to blood vessels and pressure. So, no, not here. So we talked about the heart. It's the pump. It supplies the pressure. We want to talk now about the distribution system, the blood vessels that allow the blood to flow. And when we're talking, of course, about the blood vessels, we're going to talk about flow and pressure. And when we're talking about flow and pressure, we say that this is a discussion of hemodynamics. Right? The changes in flow and pressure we call hemodynamics. And when we talk about hemodynamics, we go back to an equation that we learned at the very beginning of the course, an equation for both flow, and that was that flow is equal to the difference in pressure over the resistance. And of course, we know that the heart creates that difference in pressure. The vessel is going to offer resistance to that flow, so let's talk about factors that influence resistance. And we can set up a little equation here that we're never going to put numbers in, folks. So this is something that will help us in terms of a concept. And it says that the resistance is equal to the length of the vessel times the viscosity times a constant 8 over the radius to the 4th power times pi. Okay, so let's look at each of these factors that influence the resistance of flow in the vessel. Viscosity. The thicker the blood, the more resistance there is, right? So if the blood is very thick, it's hard for the blood to flow through the vessels. Not too hard to think about, right? If you're pouring pancake syrup on your pancakes and it's very thick syrup, it comes out very slowly. If it was very thin syrup, it would come out quickly, right? So the viscosity of the blood plays a role. The length of the vessels. You might think that your vessel length in your body is constant, but it varies. If a woman is pregnant and all of a sudden her abdomen's out to here, do you think she had the same length of vessels that she had before? She can't possibly, right? You have to be able to change the length of your vessels. In fact, we estimate that for every pound of fat that you add to your body, you add a mile of blood vessels, right, to supply that increase in tissue.
Every pound? A mile?
When you lose weight, you lose vessels. Absolutely. The radius of the vessels. So it turns out that the larger the radius, the less resistance. That's why radius is in the denominator. And this should make some sense, right? So if the vessel's bigger, right, greater diameter, it's easier for the blood to flow than if it's smaller, right? And it turns out that it's to the 4th power of the radius. So a small change in the radius dramatically changes the resistance, right? So if the radius is going to get larger, right? The radius gets larger, the resistance is going to get smaller because it's in the denominator. Make sense? We can actually change the diameter of our arterioles 4 times. And so then if you took that 4 times 4 times 4 times 4, right? We're talking about a huge change in the resistance of the vessel. And then pi is in our denominator here. So I'm going to say a nasty word again. Algebra. Okay? So we know that flow is equal to the difference in pressure over the resistance. But we just went through and looked at resistance. And so what if I go in now and I substitute these factors that are in here for the resistance into this equation? So I'm going to end up then with a difference in pressure times the radius to the 4th power times 8 over the length times the viscosity times pi. Do you see how I did that? All I did was I substituted what we worked out there for the R. Oh, I switched the 8 pi, sorry. Good catch, good catch. I inverted everything else, but I didn't invert my pi and my 8. No, I ate the pi, no. So all I did was I took this equation, right, and I substituted it for where that R was, and I ended up then with this equation. And this equation is named after some Frenchman that discovered it, and I never say his name right, but I'll give it a try. Poiseuille. law. We can say Poiseuille, I guess is another way. Anybody want to work on my French? Poiseuille, maybe? You can go online and I'll let you try. So it says that the flow is equal to the difference in pressure times the radius to the fourth times pi over the viscosity times length times 8. Now, again, we're never going to put numbers in here, folks. This is not going to be something that we're going to solve for. Instead, we want the concept. So that if I say to you that all factors have remained the same except the radius of the vessels has decreased, what has this done to the flow? What would you tell me? Radius is decreased. What happens to my flow? Flow decreases because the radius is in the numerator. Right? Difference in pressure increases. Flow increases, right? So we use this for the concept. Engineers use this same equation when they're trying to figure out flow of water in a pipe. So when somebody, an architect, figured out how to plumb your house that you live in, they had to take into account Poiseuille's law. They said, well, how much flow do we need? How much difference in pressure do we have? What size pipe do I need to have? Right? And of course, if it was longer pipes, they had to take that into account. Same thing happens in our body. Okay? So this is Poiseuille or Poiseuille's law. Let's look at the individual blood vessels and how they affect flow and pressure, what their role is. So we're going to start with the arteries. You learned in anatomy that arteries have a very thick wall. Look at their wall compared to a vein, right? So a very thick wall, lots of elastic tissue, lots of smooth muscle. It turns out that because they're very large radius, they offer very little resistance to the flow of blood, and because of their elastic tissue, they act as a pressure reservoir. Okay? They're going to act as a pressure reservoir. In fact, if we looked at the flow of blood out of the arteries during a normal systole diastole, only about a third, you don't need to know this, but only about a third of the blood that's going to come out of the arteries comes out during systole of the heart. The other 2/3 comes out during diastole of the heart. So how can that be? The heart's in relaxation, but blood still keeps coming out of the arteries because of the elastic tissue that's in the arteries. I have a garden hose at home. It's supposed to be a super duper hose. It's not supposed to kink much. And it's a really flexible hose. So typically if I put a nozzle on that, I'm going to spray something down. I put my nozzle on, I turn on the faucet, I spray something down. If I walk over and turn the faucet off, and now I take that nozzle and I point it at my face, and I squeeze it, the water's turned off. Anything going to happen to me? Yes. I'm going to get a face full of water. How come? Because the hose is elastic, right? So when the pressure was on, it stretched the hose. Even though I turned off the faucet, if I open the other end, it's contracting, right? Coming back to its normal position, not really contracting, right? The elasticity, and that will squeeze the water out. The same thing happens in our arteries. The heart goes through systole, it puts a big old stroke volume out into the arteries, they stretch, the semilunar valves close behind that, and now the arteries come back to their original size, and they're pushing blood in front. Okay? So that's maintaining the pressure in that system. We like to know how much pressure is in that system, and to check the blood pressure, we use an instrument called a sphygmomanometer. Okay? A sphygmomanometer. For 1 point on a quiz or lecture test, I'm going to ask you to correctly spell sphygmomanometer, because I don't think you can say it if you can't spell it. If you think about instruments in a doctor's office, folks, probably sphygmomanometer, stethoscope, thermometer, right? I mean, that's really the basic stuff that's going to be there. You're going to be educated people. You should know what those instruments are, right? So it's a sphygmomanometer. You go out into the world, you go into a doctor's office, next time they're taking your blood pressure, ask them what that instrument is that they're using. And they'll probably say, oh, it's a BP cuff. And then say, well, but what's it really called? And if they say it's a then you say, oh. But if they say sphygmomanometer, you say, oh, when did you have Gary Fuller's class? All right. So we check the blood pressure using a sphygmomanometer. Those of you who have lab, you got a chance to do that last week. Let's talk a little bit about how this works. So you can take blood pressure directly by putting a catheter in an artery. It hurts, it's very invasive, high risk. We don't do that. Instead, we take blood pressure indirectly by putting the sphygmomanometer cup on the arm. We inflate the cup to occlude the artery, to close off that artery. Once that artery is occluded, all right, so we're pumping up the pressure. Once it's occluded, a little hard to see, but here it is, it's cut off. No blood is flowing. If you listen with a stethoscope right now, you won't hear any sounds because no blood is flowing. If you leave that sphygmomanometer pumped up, it's a tourniquet. The arm will eventually drop off. It's used as a tourniquet regularly in the surgeries and in emergency rooms. If we slowly let off the pressure, eventually when the heart goes through systole, when it's contracting, it will squirt a little bit of blood through. There will be turbulence. They're trying to show turbulence. And you'll hear a tapping sound. When the tapping sounds begin, we record that pressure as the systolic pressure. There's a name for these sounds. We call them Korotkoff sounds. Okay? They're called Korotkoff sounds. So you're going to hear tap, 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 tap as the pressure comes off. Okay? So you're listening. When it first started, we write that one down. That's the systolic pressure. So maybe the systolic pressure was 140 millimeters of mercury. Okay? We continue to listen, and as we're listening, eventually the artery is fully open, so it's no longer occluded. And when the artery is fully open and no longer makes Korotkoff sounds, the tapping will stop. We record that pressure as the diastolic pressure, because that means when the heart was at rest, there was enough pressure in the arteries to hold that artery open. And so maybe in this case, the diastolic pressure, let's say that it was 80 millimeters of mercury. So it's really about the turbulence, right, that makes this tapping sound. It's not unlike going out to a meadow. If it's a nice flat meadow and there's a stream running through it, it'll be very quiet, right? But if you follow that stream to where it started to come out of the meadow and go over rocks, it makes a lot of gurgling sound. You would hear that, the tapping sound as it flows over that. My folks live in Auburn. They live right next to an irrigation ditch. And my dad likes to hear the babbling of the brook at night when he sleeps. He doesn't do this anymore, but for years, he would go out and throw giant boulders into the irrigation ditch so that as the water went through, it made the nice gurgling sound so for when he was sleeping. Of course, the ditch tenders would come along and throw all those boulders back out, right, to clear out the ditch. He'd wait till they were gone, then he'd go back and throw them all back in. And I said, Dad, that's really not really good. He said, oh, there's plenty of water, it's all getting down the stream. But anyway, he doesn't do it anymore. But anyway, you have the idea.
Why did he stop?
He got old, right? My dad's 85 now, so it's a little hard to get down in the ditch, right? Throw stuff in.
I can relate to that.
Yeah. So, let's see, what else was I going to tell you here about? So these sounds are made by the turbulence in the artery. Years ago, I had a student that went up to Stanford. She was trying to get into their physician assistant program at Stanford. And during the course of the interview, one of the questions that they asked her is, what makes the sounds that you hear when you're taking heart sounds, right? When you're listening to the lub and the dub. They wanted to know what's making the heart sounds. Well, she proceeded to describe Korotkoff sounds, what's making the Korotkoff sounds. And that was making the heart sounds. They're two very different things, right? So if you hear heart sounds when you're listening down here, if you hear lub dub, let me know, because we'll make you famous. You have incredible hearing if you could hear lub dub. Right? You're supposed to be hearing Korotkoff sounds here, and you hear lub dub over the heart. Yes?
Sorry, could you spell that word Korotkoff? Where is it?
There it is.
Thank you. Is that a person's name?
It is. The person that discovered these sounds. Okay, so that's how we take blood pressure measurements in the arm. Another pressure that we're interested in physiology is something called the pulse pressure. The pulse pressure is the difference between the systolic and diastolic values. So you simply subtract diastolic from systolic, and you'll have the pulse pressure. So in our case, the pulse pressure would be what? We can do this math. 60, right? 60 millimeters of mercury. Okay, so that's the pulse pressure. Another pressure that we're interested in is something called the mean arterial pressure. The mean arterial pressure is the push, right? So pressures are going up and down all the time, right? Because of systole, diastole. But what's the average push through the arteries? You might think that you would just average the systolic and diastolic, but we don't. A better estimate of the mean arterial pressure is to take the diastolic pressure and add a third of the pulse pressure. So in our example, we take the diastolic pressure, 80, and then we're going to add a third of the pulse pressure. So a third of 60 is 20, right? So this is 20. And so the mean arterial pressure in this case would be 100 millimeters of mercury, right? That would be the actual average pushing the blood through the circulatory system, at least through the arteries. All right, so we have the arteries. Let's look at the arterioles, right? So the small arteries. Your arterioles are the regulators of pressure and flow in the body. Okay? These are the regulators of pressure and flow. And to help us understand how this works, I like to use a tank model with blood's coming into this big tank. The tank is representing the arteries in the system, and the arterioles are the outflow from the tank. And if we dilate the arterioles, what's going to happen to the pressure in the system? It's going to go down. If we constrict the arterioles, pressure will go up. And again, as I mentioned earlier, arterioles can change size 4 times. We know that for each time they change, it's to the 4th power, right? So if you do the math, it comes out to be 256 times change in the resistance that we can change in these arterioles. So what kind of things affect these arterioles? Well, one of the factors is something that we call local control. So local mechanisms that can affect the size of the arterioles. One of these is something that we call active hyperemia. Okay? Active hyperemia. Hyperemia means an increased blood flow to an area. Active because we're doing something with it, right? So as we use tissues, the use of those tissues produces metabolites. Mostly what we're talking about here is carbon dioxide, which will lower the pH. Okay? So as we exercise, as we use tissues, that produces CO2, which lowers the pH, and that will dilate the arterioles. Also, there's a decrease in oxygen, and that helps to dilate the arterioles as well. Okay? So we call this active hyperemia. Those of you that work out, right, if you go and lift weights, after you're done lifting weights, there's a couple of things you probably notice. The muscles are usually kind of puffed up, and the veins are usually puffed up. Because while you were exercising, you produced carbon dioxide, you lowered the pH, and the blood vessels dilated. And we call this active hyperemia. Another factor is something that we call reactive hyperemia. Reactive hyperemia means we're reacting to previous ischemia. Okay? Reacting to previous ischemia. We know what ischemia means. Low blood flow. So if there's low blood flow in an area, pH tends to drop, oxygen levels drop, and those will cause blood vessels to dilate. Years ago, I used to do a lab that I thought was very interesting. Students were always a little hesitant to do it, but I would have the students, when they put the sphygmomanometer on their arm, pump it up and leave it on the arm for 5 minutes. Okay? Of course, during the 5 minutes, the arm became very, very pale, right? People started complaining that it was hurting, right? But when they released the valve, the arm would turn a bright, bright red. Reactive Hyperemia, right? Due to the previous ischemia, the arm had incredible dilation of the arterioles, and blood flow would come in there trying to bring things back to normal, right? Bring the oxygen levels up and removing the CO2. Another factor that can affect arterioles in a local mechanism, something that we call chemical release. And one of the major chemicals here is histamine. So that if histamine is released locally due to inflammation, it will cause arterioles to dilate. And you've all experienced this, I think most of you anyway, so that if you get poison oak or if you have allergies, the histamine dilates the blood vessels, the arterioles dilate, and the area will turn red. Why did it turn red? Because of increased blood flow to the area due to dilation of the arterioles. Okay, so the release of certain chemicals can cause dilation. And then finally, I have long-term autoregulation, which is something I kind of mentioned already. Over time, due to increased size of the tissues or decreased size of the tissues, you can add or remove blood vessels and change the size of the arterioles and arteries in the area. Under autonomic control, well, we already know that it's the sympathetic nervous system that has the major control of arterioles. And so depending upon whether we need to get more blood flow or less blood flow to the area during an emergency, we can dilate or constrict the arterioles, right, under sympathetic control. Parasympathetic, I kind of mentioned this when we were doing the autonomic nervous system, doesn't have much of an effect. It can dilate blood vessels a bit in the gut. It has dilation in the genitalia as well, but not much effect on blood vessels. That brings us to the capillaries. The capillaries. When I was on sabbatical years and years ago, I went to a really interesting seminar put on by a British physiologist, and he was talking about changes of blood flow in the lungs and different research that he had done. I couldn't really get much out of the lecture because of the way that he said capillaries. The British don't say capillaries. What do the British say? Anybody know? Capillaries, right? And so he kept saying the capillary this and the capillary that, and it's like every time he'd say capillary, it's like somebody was whacking me, right? And so it's like I had a hard time paying attention to his lecture. At any rate, if we take a look at the capillaries, we find they're microscopic, right? So we can't see capillaries, I'll stop, but we can't see the capillaries with the unaided eye. So when they first did research trying to figure out the circulation in the body, it's kind of hard for us to imagine this, but they figured out that blood came through the arteries out of the heart and came back through the veins. This guy Harvey figured this out. But they couldn't tell how the blood got from the arteries to the veins because they couldn't see capillaries. Right? So he said, I don't know how it gets there, but it does. It comes back through the veins because it went from the arteries to the veins. So they're microscopic, they're single cell layer thick. Okay? So only a single cell layer thick, and there's little slits between them so that fluids and small molecules can go easily in and out between the capillaries and the tissues. Large particles, proteins, red blood cells can't, but there are little slits in there.
Excuse me, you said the slits are between them?
Yeah, between the cells. So it's trying to show
between
you here.
cells.
There's a cell, there's a little slit right between the...
But not between the vessels?
No. Between the cells of the vessel. So if we look at capillaries, one might think that all the capillaries were the same, but it really turns out that there are what we call true capillaries and thoroughfare capillaries. This diagram calls them a little something different, but it's the same idea. So in this diagram, here would be our true capillaries that are serving the tissues. And here's what we would call a thoroughfare capillary. They're calling it a metarteriole. I like thoroughfare capillary. So the start of each capillary has a precapillary sphincter, a little bit of smooth muscle. There's no smooth muscle in capillaries because I just told you capillaries are a single cell layer thick. They're simply made up of endothelium. That's it. All right? So there's no muscle in a capillary, but at the start of each capillary, there's a pre-capillary sphincter, a small, smooth muscle circle. So if we're not using tissues at a particular time where we don't really need to be having blood flow into those tissues, we could just bypass them by keeping the pre-capillary sphincters closed and allowing the blood just to go through this thoroughfare capillary, go right from the arterial to the venule, and come back. If all of a sudden you need blood in that area, you can start to open the pre-capillary sphincters and more blood will flow in. So capillaries are microscopic. They're so small that red blood cells go through them single file. Now if you think about that for a minute, we learned that, I didn't have it up there, but in resistance, right, the smaller the radius, the greater the resistance. Right? If the radius is small, there's a great resistance. So one might think that the capillaries offer a large amount of resistance. Wouldn't you think that? Because they're so tiny. They don't. They don't offer much resistance, and they don't offer much resistance because of the total cross-sectional area of a capillary. Right, so let's take a look at this cross-sectional area. So this is trying to show you that when we go from the arteries to the capillaries, this is cross-sectional area there. There's a huge cross-sectional area in the capillaries. If you take a look at your spaghetti colander at home, lots and lots of tiny little holes. If you turn your faucet on and walk over and hold your spaghetti colander underneath it and look at the water flow underneath it, what do you notice? The water just goes right through it. Well, how come? There are so many holes, right? So even though each little hole would stop and slow the flow of water in your colander or blood, because there's so many holes, the water just runs right through. So the large cross-sectional area that we have in capillaries means that there's very little resistance to the flow of blood. It's estimated that in an average adult, there are about 60,000 miles of capillaries. Right? If you could remove all of my flesh and just have my capillaries showing, I'd look like a giant sponge of capillaries. Every cell in your body is no further than a millimeter away from a capillary so that they can get blood flow. Right? There's a couple of strange exceptions, like the cornea of the eye, the lens, a couple of things. But huge amounts of capillaries everywhere. Yes?
Do the capillaries take the waste with it as well?
Absolutely. So this is where nutrient and exchange and waste exchange occurs, right? Nutrient and waste exchange is going to occur here. So a huge cross-sectional area means very little resistance. There's something else that's pretty interesting. This is showing pressure. I'm going to go with my other one here for a minute. In addition to having a large cross-sectional area, or because of the large cross-sectional area, look what happens to the velocity of blood flow. So here's the cross-sectional area, right? Look what happens to the velocity of blood flow when we get to the capillaries. We're going along pretty fast, and then, whoa, it slows way down, and then picks up as we come back in the veins. So by having this huge cross-sectional area, we get a very slow flow of the blood. Let me give you an analogy. I grew up in the Sacramento Valley. One of the areas that I used to like to go to as a kid was Folsom Lake and the American River that comes in and out of Folsom Lake. There's lots and lots of whitewater rafting above the Folsom Dam, right? Above the lake, so people whitewater raft. Well, why don't they whitewater raft on Folsom Lake? It's very, very calm, but the same amount of water is running through. If you go look below the dam, the water's moving very fast coming out of the dam. Why is it going so slow in the lake?
It's wide.
The big, wide area of the lake, right? So the water comes in at a high speed, but then it's very, very wide, a large cross-sectional area, so it's moving very, very slowly. And when we come back to the water coming out, velocity picks up. The same happens in our capillaries. So in the arteries, it's moving fast, but when we get to the capillaries, it slows down because of the high cross-sectional area. and then we get back to the venules and veins, it picks up again. Well, this is very good because when we're in the capillaries, there's time for the diffusion of nutrients and waste to go back and forth. And that's all that they do. They just diffuse in and out. Okay, the nutrients and waste, because of the slow flow of blood and the slits that are in the capillaries, we have a very good exchange of nutrients and waste. So, fusion of nutrients and waste, right? We talked about that already. The next thing on my list here, I have something called capillary membrane dynamics. Okay? Capillary membrane dynamics. So, we need to talk a little bit about the pressures that are affecting the flow of fluid at the capillaries. Let's take a look at this. So this is supposed to represent the tube of a capillary. All right? So this is supposed to be the inside of the capillary. Here's outside the capillary. And if we look at a capillary, certainly the pressures will be higher at the arterial end and lower at the venule end. But we're just going to kind of look at the average pressure that we'd expect to find in a capillary. So inside the capillary, we have a pressure due to blood pressure. Right? The fact that the heart's created this pressure inside, and that pressure on average is about 19 millimeters of mercury. I don't care that you know these numbers, folks. I'd like you to work with them, but you don't have to know the numbers. So on average, about 19 millimeters of mercury of what we call hydrostatic pressure that tends to push fluid out of the capillaries. Not any different, really, than a garden hose that has pressure in it. And if you start poking holes in it, right, there's pressure inside that'll make the fluid tend to come out. Okay, so that's the hydrostatic pressure, what we call capillary hydrostatic pressure. If we look out in the tissues, there's actually a sucking action in the tissues that's tending to pull fluid out. And so we say this is a -6, meaning it's sucking fluid out. A -6 millimeters of mercury in hydrostatic pressure. That negative pressure is due to your lymph vessels actually sucking the fluid out of the tissues. So if we wanted to know the net hydrostatic pressure, I'm going to swear again, algebra. Okay? If we do algebra here and I say, all right, I have 19 millimeters of mercury pushing out, I'm going to subtract, so this is the capillary hydrostatic pressure. I have to subtract the tissue hydrostatic pressure, so minus the -6 tissue hydrostatic pressure. Close that door here. So what's my net pressure? 25 millimeters of mercury causing fluid to leave the capillaries. Right? A net of 25. And so if that was the only pressure that I'd have to consider, we'd have fluid coming out of our capillaries and we would be blowing up like balloons. Right? Pressure would be pushing the fluid out. Edema would be occurring everywhere. Luckily for us, there is an opposing pressure, a major opposing pressure. And that opposing pressure is created by the albumins that are in our plasma, that we know are there. And they create an osmotic pressure that pulls fluid back because proteins can't get out, right? For the most part anyway, so they're going to tend to pull fluid back. So let's take a look at the osmotic pressure. It shows you up there that the average osmotic pressure in the capillary is about 29 millimeters of mercury. So this is the capillary osmotic pressure. And that's going to tend to pull fluid back in. Right? It's a sucking action, right? It's going to pull fluid back in because of the proteins that are in here that can't get out. But a few proteins do leak out into the tissues, and so the tissues have an osmotic pressure as well. And it shows you here that the average osmotic pressure of the tissues is about 4 millimeters of mercury. So that's the tissue osmotic pressure. So that's a positive pressure, because it's an osmotic pressure, so it's not really a vacuum. So we got to subtract that pressure. We're going to take the capillary osmotic pressure, subtract the tissue osmotic pressure. The net will be 25 millimeters of mercury. What a surprise, they're in balance. Right? So the push out that's created by blood pressure and the sucking of the lymphatics is countered by the pulling of the osmotic pressure, pulling fluid back in. We're normally in balance. Sometimes the net osmotic pressure is called oncotic pressure. So you may see that term used. Okay? So the net osmotic pressure is sometimes called the oncotic pressure. Now, if we look at this for a minute, we can think about what's happening in a normal person with these hydrostatic pressures and osmotic or oncotic pressures. At the end of the day, when I go home, it feels really good for me to take my shoes off and put my feet up. Just like, oh, that feels good. Because my feet are bigger at the end of the day than they were at the beginning of the day. During the day, I have gravity pushing down on my legs, right, and on the blood, which causes a much greater pressure, hydrostatic pressure in my feet than I would find, for instance, in my head, right, or any place above my heart. And that increased pressure causes fluid to leak out of my feet during the day, right? So,
Leak out of your feet?
to leak out of the capillaries of the feet, right? So not coming out into the shoes, but leak out of, yeah, to leak out of the capillaries. So let's change this. We said these two were in balance. What if, right? We go back here for a minute. So we said normally, right, average, we had 19 millimeters of mercury pushing out. What if, because of gravity, that 19 all of a sudden is, let's make it 28. Okay? So if I go back and do my little equation here, the capillary hydrostatic pressure, if I turn that into 28, and I have 6, I'm going to now have a net pressure of 34 pushing out, and only 25 pulling back. The difference is going to mean fluid is going to start to leave the capillaries and accumulate in those tissues where the pressure was high. At night, when I lie down, my body picks those fluids back up, really the lymphatic system, right? But I also have less hydrostatic pressure. So that fluid is gone after I've laid horizontal. When I first get up in the morning, I go in and I look in the mirror. Sometimes I notice my face looks a little puffy. You ever notice this in the morning? Now, why is your face going to look puffy? So we've accumulated the fluid, right? And the fluid is now evenly distributed. So now that means it's evenly distributed in your head. During the day when you're standing up, right, the fluid's going down the legs, so the fluid's draining out of the head and out of your face. But when you first get up in the morning, it's now collected, in a sense, in the head. So if you want to put this another way, the best time to go shopping for shoes would be the end of the day when your feet are the biggest so that you don't get a blister. And if you really want to shop for the hat to match the shoes, shop in the morning. So that, right, because that's when your head is the biggest. So then you got shopping all day long. If you ignore my advice and you buy your shoes in the morning, okay, you bought your shoes in the morning, by afternoon the shoes might be too tight. And as you start to rub against the side of the shoe, you start to irritate the capillaries and the slits become larger and proteins will start to leak out into the tissues. And if proteins leak out into the tissues, we've changed the tissue osmotic pressure. Let's look what's going to happen. So what if my tissue osmotic pressure goes up? So instead of it being 4, because we've lost proteins outside, now all of a sudden, let's say that it's 8. Well, now my oncotic pressure, the net, would only be 21. We go back to the original here, 25, right? The hydrostatic pressure exceeds the oncotic pressure. Fluid will be leaking out, right? There's not enough pressure to pull the fluid back, right? So this is what we call capillary membrane dynamics. The constant shifting of fluids, both from the capillaries to the tissues, from the tissues back to the capillaries.
Sorry, capillary?
To the tissues?
No,
from
the word capillary.
Osmotic pressure or oncotic pressure? Capillary membrane dynamics is what we call the whole thing.
So this must be why your bottom gets bigger when you sit a lot.
Anything that's below the heart is another whole thing. I'm a little slow on the uptake there. Let's look at a couple of abnormalities. One of the abnormalities is something that we call Kwashirokor. Okay? Kwashirokor. So sometimes you'll see in newsprint or on the television, they'll say, help the starving children of Somalia or Ethiopia or some place, right? And so they'll show a picture, usually pretty similar to this, and you look at this and say, gosh, they're starving, but man, look how big their abdomens are. They look like they've been eating too much, right? I mean, why is their abdomen so large? Well, in this particular condition, disease, we call it Kwashirokor. The children, the people, but it affects the children dramatically, have not been receiving enough protein in their diet for their liver to make plasma albumins. Okay? So they're not making adequate amounts of plasma albumin. What's going to happen to the oncotic pressure of the capillaries if they don't make enough albumin? It's going to go down, right? So if it's normally it's supposed to be 29, what if all of a sudden that drops to 20 because they don't produce enough albumin for their plasma? If there's not enough albumin for the plasma, the capillaries can't pull the fluid back. There is a large cavity in the abdomen, and fluid begins to accumulate in the abdomen. So it's not that they have a really full stomach from eating, it's in fact due to a lack of eating and an accumulation of fluid in their abdomen. The general term that we use for accumulation of fluid in the abdomen is ascites. Okay? So that means fluid has accumulated in the abdomen, in this case due to starvation. Sometimes a person has cirrhosis of the liver due to excessive alcohol consumption, due to viral infections, hepatitis B. Their liver is no longer functioning normally, right? So they have cirrhosis. If the liver cannot produce adequate amounts of liver proteins, the albumins, they'll have a decrease in the plasma osmotic pressure, right? The capillary osmotic pressure, right? Because they're not making plasma proteins, and they will develop ascites, right? A lack of proteins to pull the fluid back. Fluid's going to tend to accumulate in the abdomen. So in that case, it's because the liver is malfunctioning, not because of starvation, certainly.
Is that in the actually intestines? Or
No, the abdominal cavity. So surrounding cavity, surrounding the intestines. Okay, so that was the capillaries. Let's leave the capillaries. Let's talk about your veins. The veins are large diameter. They offer very little resistance. Okay? So large diameter, very little resistance. And it's good that they offer very little resistance because there's very little pressure left by the time we get to the veins. Let's take a look just for a minute. Right? So this is trying to show, here's the aorta, and of course we see the surges in pressure in the arteries, right? But if we look at this, pressure's dropping. We get down to the capillaries. When we get down here to the veins, there's very little pressure left. Now it's still greater than what's in the heart because, right? I mean, blood's only going to go from where there's high pressure to low, right? So the highest pressure, of course, has to be in your aorta. The lowest pressure has to be late vena cava, right atrium. But there's very, very little pressure left. In fact, as we get to that late vena cava, right, it's going to be very close to zero. Okay? Very close to zero when we get here. So very small amounts of pressure, but luckily a large diameter and very little resistance. There's actually the majority of your blood at rest anyway is in your veins. Again, not that we need to know this, but about 60% of your blood right now is sitting out there in the veins, slowly coming back to the heart. So the veins, because they have such low pressure, need help. to get the blood back. And luckily for us, our veins have valves. You learned this in anatomy, right? So there are valves in our veins that help with one-way flow. So this is trying to show that these one-way valves allow blood to move towards the heart but prevent backflow. You can demonstrate the veins in your, or the valves in your veins if you have big veins like mine. A little hard to see, right? I don't know if you'll be able to see it. Not enough light there. Maybe you can tell. But if I pinch off the vein distally and I push the blood out, I've got a valve right there. Can you see that at all? Yeah. If I let go, the blood flows back in, right? So I punch it, pinch it off. There's a valve right there. Now if I let go, right? So blood can only flow one direction. This is in fact how that guy Harvey figured out that there was one-way flow in the veins towards the heart. Those one-way valves help move the blood because of our skeletal muscle pump. So here's a vein in between two muscles or in a muscle. When the muscle contracts, it squeezes the vein, which pushes on the blood. Well, the blood can't go backwards, down. It can only go forwards towards the heart. So every time the muscles contract, it squeezes the blood towards the heart and helps to push the blood towards the heart. So when you are walking, you're squeezing the veins and it's helping to push the blood back towards your heart, having these one-way valves.
Gary?
Yes?
Those, I see the two-dimensional picture. Is it?
Three-dimensional.
Yeah, but are they four of them? Or,
No,
or
just
like
two.
They're just two of them on each side? Okay.
Yeah. Okay. When we get older, our veins get very close together, and so we say you have very close veins. Oh, no, varicose veins, sorry. So here is a very bad case of varicose veins. The valves that are in our veins can wear out. Okay? Those valves can wear out. And particularly, they tend to wear out in the lower extremities where there's lots of gravity pushing down. As the gravity pushes down and the valve wears out, the pressure gets greater than in the tube on the sidewalls and the next valve. So if you think about, right, a nice long vein here that had maybe 3 sets of valves, right? If all of a sudden this valve wears out, then the pressure from here is exerted on this valve way down here, and there's a sidewall pressure that's going to tend to push out, whereas before, right, the pressure was broken up. This causes the varicosities, right, the increased size of the veins. What causes this? There are numerous things that can contribute. Some of it's genetics. Certainly, we know that pregnancy is a contributing factor, so that when the woman has the fetus in the abdomen, it pushes on the large veins, returning blood towards the heart, and tends to trap the blood in the leg. So the blood that's trapped has increased pressure. People that stand in one position all day long and don't move around much, they're not having the skeletal muscle pump. So it's a classic problem in barbers and hairstylists, sometimes in factory workers if they're standing in one place, right, doing something at the table all the time. We can help these people by giving them soft-soled shoes, soft rubber mats, so that any movement tends to increase the muscle contractions. And they can also wear elastic hose, so that, again, any movement causes the push against the veins and pushing the blood up. If the person decides to have the varicose veins removed, sometimes it's cosmetic, sometimes they're actually large enough, like this person, where you're going to start to have maybe some pooling of the blood. They can be removed. The old way of doing it is not done much anymore, but I always like to describe it because it's so gross. So they would take the large vein and they would tie it off at the top and at the bottom. They would run a wire down into the vein and then they'd attach the wire to the wall in the lower part, and then they'd just pull the wire out. So they would just strip the vein out. These days, they use laser to destroy the vein. They can also use certain chemicals that will kill the cells of the vein. Other veins in the area then will have to take up the flow, right? They'll have to return the blood. Yes?
Is there a reason why I've seen people have varicose veins extremely large just on the right leg and not the left leg?
I have no idea. Maybe people tend to stand more on that one leg, right? So you don't have much movement. I don't have a good answer for that. I don't know that that's really the case. I don't have the statistics. Okay, so those are very close veins. Your lymphatic vessels. So we have arteries, capillaries, veins. You know from anatomy that you have an entirely separate set of vessels in the body, the lymphatic vessels. There's certainly lymphatic lymph nodes as well, which we'll talk more about when we get to the immune system. But there are accumulations of these lymph nodes, axillary region, genital region. But throughout your body, you have these lymph vessels that pick up fluid that has leaked out and return it because you're constantly leaking. Okay, so they're gonna pick up the fluid and return it to the circulatory system. Kind of surprising here, the whole body is drained into something called the thoracic duct, which empties into the left subclavian, except the upper right quadrant, which has its own little kind of drainage area, and it drains into something called the right lymphatic duct. So if we look at these lymph vessels, they're composed of smooth muscle. They have endothelium as well, but smooth muscle with one-way valves. When these vessels constrict, they contract, because they have one-way valves, they create a pump that pumps fluid to the circulatory system, returning the fluid. Can you kind of see? So it's like the veins, only active veins that can constrict on their own and pump the fluid towards the heart. So they're constantly sucking the fluid out of the tissues. That's why we had that negative pressure when we were looking at that hydrostatic pressure. Other functions of the lymphatic system besides picking up fluids are these lymph vessels. In your intestines, the lymph vessels are involved in picking up fats and bringing the fats to the circulatory system. When we get to the digestive system, we'll talk about that. I probably should put another one, abnormalities here. So if the lymph vessels can't return the fluid, then the appendages can enlarge. Okay? So if the vessels can't return the fluid, the appendages can enlarge. There's a condition called elephantiasis that's caused by a particular organism, happens to be, you don't even know it, but a filarial organism that's spread by mosquito bites, particularly in the tropics. So this organism gets into the lymphatic system and plugs the lymph vessels up. When the lymph vessels get plugged up, the tissues begin to get edema, and the edema causes then the tissues to enlarge. And so here's a couple of people with very, very severe elephantiasis. You can get this lymphedema for other reasons. So if, for instance, a woman has breast cancer, when they do a mastectomy, very commonly they'll also remove lymph nodes in the area. And when they remove those lymph nodes and lymph vessels, the woman might end up then with elephantiasis, but really we just call it lymphedema, right? So a swelling of the appendage, typically an arm, due to the lymph vessels not returning the fluid.
Does the body recreate new lymph nodes, or?
You know, not that I know of.
It doesn't.
Yeah, so Nan says no, and as far as I know, they don't. You know, in the past we've always said, you know, no new muscle cells. No, there may be some, but not well anyway. To some extent, this picture right here influenced me becoming a physiology instructor and getting interested in anatomy. So when I was 11, 12, 13, right in there somewhere, my dad was a pharmacist. And so one of the things I started doing is I'd go in and look at his medical books that he had, and I would see really neat pictures of different diseases. Oh, this is very cool. Well, one of the pictures that I looked at was a picture of this guy. They also had a frontal picture of him. And if you look, his scrotum is dramatically enlarged. As a young man, right, young boy really, when friends would come over, I'd say, "You want to see something amazing?" Right? And they go, "Whoa!" And I say, "This is kind of cool, right?" I mean, hey, well, there you go.